Our next speaker for this day is Dr. Sangeetha. She'll be talking to us on pneumococcal vaccines. She's an assistant professor in the Department of Pulmonology, SRMC, and she's also a visiting consultant in Vijaya Hospital and Apollo Family Clinic. She's been involved in lots of various research products, and she's also received the gold medal for her best performance in MD. We welcome Dr. Sangeetha to deliver her talk on pneumococcal vaccines.
Good morning, everybody. I would like to thank my HOD and Dr. Gauri Shankar for giving me this opportunity to present my talk in this forum. Pneumococcal vaccines. I guess this topic was included because of all the pressure all of us are getting from various multinational companies telling us my product is superior, no, my product is superior. So this is an attempt to try to make it simpler. So why this focus on pneumococcal vaccines? In the community acquired pneumonias, the commonest pathogen that we encounter is Streptococcus pneumoniae. So if we are able to bring down the incidence of pneumococcal pneumonia, we are able to control a huge chunk of community acquired pneumonias. And it's a very difficult proposition to even find a vaccine for these, because the vaccines are all based on their polysaccharide capsules. These polysaccharide capsules are what cause the virulence, give the virulence to the organism. It is this capsule which prevents the organism from being phagocytosed or opsonized by the host defense. And based on these polysaccharides, you have close to around 90 serotypes. And each serotype, the prevalence of them depends on the geographic distribution, and then even within a given hospital environment, with time, the prevalence of a particular serotype varies. Who is at risk of pneumococcal infections? Everybody. But those who are at an increased risk are those who are at the extremes of age, who have a chronic lung disorder like COPD, bronchiectasis, and then those who have chronic cardiovascular diseases, CVA patients, diabetes mellitus, those who are on chemotherapy, transplant patients on immunosuppressants. So there are a whole lot of people who are prone for pneumococcal infections. So what is the path that was taken to control this, and why this path to control this? We all know that the drug resistance is on the rise, and as the drug resistance increases, we are finding it more difficult to handle the patients, more so in the ICU setup. So by vaccinating a patient, we are bringing down the incidence of the disease so that we don't have to tackle the patient once they have got the infection and then deal with a multi-drug resistant bug. Initially, the process of starting a vaccine for pneumococcal pneumonia came up in the 1911, wherein they took the whole bacteria as such and then tried to use a less virulent strain as a vaccine. However, it had a lot of vaccine reactions, following which it was aborted. And then they thought, like, the polysaccharide capsule is what is antigenic, so let us go in and try to attack the polysaccharide capsule. And then they started isolating the major serotypes which were prevalent, and then they isolated the antigens and created a vaccine using them. So this happened in the 1970s, wherein initially they isolated 14 serotypes based on their polysaccharides, and then the 23 serotypes which is currently available. After that, they decided, like, we need to enhance more, we need to give a better immune setup. So they started conjugating these. If you see the polysaccharide antigens, the antigen per se are very small. And we all know, like, you need an antigen of a particular size in order to cause a T cell mediated immune response. So they found that these polysaccharide capsules were very small, and so the third generation vaccines were, why don't we increase the immunogenicity of the vaccines by attaching a protein carrier to the polysaccharide capsule. So the third generation were the conjugated vaccines, where the polysaccharide antigens were conjugated with a carrier protein to increase the size of the antigen so that there is a better immune response. So those are From 2000 onwards, you have the various conjugated vaccines into the being. And then currently under development, like we know that these polysaccharide capsules are varied. So when we take 23 polysaccharide polyvalent vaccine, it is only sensitive against those 23 serotypes, not against the others. So we know it is unique for each serotype. In order to bring a consensus and try to bring a vaccine which will be effective against all the 90 serotypes which are prevalent, they are now doing trials to bring out a protein which is common to all the serotypes. So this vaccine is under trial, and if it comes out, then we might not have the fight of inferiority like 13 polyvalent or 23 polyvalent, which is superior and what gives you a better immunization. So currently we have two vaccines which are available in the market. One is a polysaccharide pneumococcal vaccine which has 23 serotype polysaccharides in it. And we have a conjugate vaccine which has got the antigen of 13 serotypes. So what is the controversy? What is the difference between the two? Why is it that we need to decide which is better? So if we are going to take the polysaccharide vaccine, the polysaccharide vaccine has got 23 different serotypes which are incorporated in them. So the defense which they give you, the immunity they give you is against a larger spectrum of pneumococci. Whereas your conjugate vaccine can give you an immune response only against 13 serotypes. And if you see because the antigen size is very small in the polysaccharide, they give you a larger load of antigen in your polysaccharide vaccine. So they give you close to 25 micrograms of each of your antigen, each of your polysaccharide antigen in your polysaccharide vaccine. Whereas when you take a conjugate vaccine, the antigen load per se is very minimal. It is only 2.2 micrograms, but the whole bulk is your conjugated protein, which increases the size of the antigen which is being presented. And initially the conjugate vaccines were all for the pediatric age group because preservatives used in the vaccines were 0.25% phenol, which caused a lot of adverse reactions. So the conjugate vaccines are free of any preservative. That is one advantage of an conjugate vaccine. And these conjugate vaccines, because they have a larger size, they are going to stimulate the T cell mediated response, and there is a formation of memory cells, so that the next time when you give a vaccine or when there is an infection, there is going to be a better immune response, an augmented immune response, preventing an infection. And whereas when you take a polysaccharide vaccine, the small antigen is going to stimulate only the B cells, so it is a temporary antibody response which is not going to be stored in the memory cells. There are various studies. I don't want to go into the studies because we are all interested as to what the studies conclude. So there were a lot of randomized controlled trials and there were a lot of case control trials, and there was a Croatian meta-analysis of all these trials. And then the author concluded in the Croatian meta-analysis saying that the polysaccharide vaccine helps to prevent an infectious pneumococcal disease. It does not prevent mortality or an infection of pneumonia on the whole. I guess we should understand that. Because this is a pneumococcal vaccine, it is supposed to give us a vaccination only against Streptococcus pneumoniae. It is not a blanket cover against all the bacterial pneumoniae. So, and it is not going to prevent an death from all the pneumoniae. It is only the invasive pneumococcal disease that it is going to protect you against. And it does not give you a blanket protection for the mortality. So it gives you a better immune response so that your body is able to defend itself. So it can control the extension of the disease, it can control the bacteremia in a patient with a pneumonia, but it is not going to affect the overall mortality. So finally, coming to what do I use? When we have two, there is always what should we use? Especially when you have all the multinational companies coming and saying mine is superior, and then each one of them giving you various studies to substantiate their claim. So now the advisory committee for immunization protocol of the CDC met, and this is the latest 2014 guidelines. According to the latest guidelines, they say anybody who is more than 65 years of age, not immunocompromised, it is sufficient if we give a polysaccharide vaccine. And in patients who are going in for an elective splenectomy or an elective immunosuppressive therapy, because we know that we're going to put a patient on a cancer chemotherapy, we know we're going to go do a transplantation for a patient and he's going to go in for a lifelong immunosuppressive therapy. So when you are doing an elective treatment of a particular patient, you can always go in for a PPV 2 weeks prior to the elective procedure. And in all patients, all adults, actually this protocol I have taken is only for the adults because we deal with the adult patients. In all immunocompromised adults, that is those who are more than 19 years of age, if they are not vaccinated earlier, the current strategy is to give them a conjugate vaccine first, so that you are trying to build up the immune response with a memory backup. And after that, you follow it up with a polysaccharide vaccine 2 weeks later, so that you are augmenting the immune response that you have initiated and you are producing an immune response to more number of serotypes. So this would be the ideal strategy. And suppose somebody comes and they say, I have already taken a polysaccharide vaccine, so you want to give them the best. So can I give a conjugate vaccine now? If that is the question, yes, we can give it. But what we need to ensure is there should be at least 1 year span between your polysaccharide vaccine and your conjugate vaccine. So when we give a conjugate vaccine, we can follow it up with a polysaccharide vaccine within 2 weeks, after 2 weeks. But when we are following a polysaccharide vaccine with a conjugate vaccine, at least 1 year should have lapsed before your polysaccharide vaccine. And even if the patient has received multiple doses of polysaccharide vaccine, you can still go in for a conjugate vaccine. Only thing you need to ensure is there should be a 1 year lapse from the previous vaccination. And in those patients who are immunocompromised and they don't know, like they don't know if they've had a pneumococcal vaccine or not, you can still give them a conjugate vaccine. So this is what the latest ACIP guidelines have come out with. To conclude, the polysaccharide conjugate vaccine, the pneumococcal conjugate vaccine, enhances the immune response to your polysaccharide vaccine. The pneumococcal conjugate vaccine enhances the immune response to your polysaccharide vaccine. So it is an additive effect. So there is no point in saying one is superior to the other. They work in synergy. They help to enhance the immunity. And your polysaccharide vaccine offers you an immunoprotection against a greater number of serotypes. So the ideal formulation would be like to give a patient a conjugate vaccine, follow it up with a polysaccharide vaccine to give the patients the maximum benefit. Thank you.
Thank you, Dr. Sangeetha. On behalf of the Institute Hospital, we would like to thank Dr. Sangeetha with a small moment.